Hi again, guys. So this is I titled this "Kids Eat the Darndest Things," and they really do. So if you are any type of pediatric generalist, specialist, even if you're a big toe doctor, or a nurse practitioner, or a healthcare provider, if your neighbors are aware that you're in healthcare and something happens, you're going to be asked, what do I do if, you'll be asked questions outside your field of comfort. So we're going to go over the basics of what's important for you to know, what to think about with ingestions, caustic and foreign bodies. It's sort of like the who, what, where, when, what to do about it. Goals of this talk, we're asked to come up with goals and objectives whenever we formulate talks. So obviously we want you to recognize signs and symptoms of foreign body and caustic ingestion in children, diagnose and plan appropriate management of such ingestions. But most importantly for where you're at probably today is you want to correctly answer any board questions pertaining to the subject matter. And I think as long as you stay awake and pay any attention, you may possibly help somebody in the future save a life. It may be your own child, grandchild. Again, you may be the auntie or uncle. But let's get started. So who is most likely to swallow a foreign body? Well, the little culprits typically are children between the years of 1 and 3 years of age. So they're the ones most typically putting something in their mouth, getting it stuck, and that you'll be asked the question about. They account for almost 80% of foreign body ingestions in patients. Adolescents and adults make up the other 20%. Usually those patients have some underlying esophageal abnormality, so whether they've had a stricture due to a prior T fistula repair or other surgical anastomosis, or they may have a mucosal abnormality. I think Dr. Selvakumar is going to talk a little bit about eosinophilic esophagitis. Those patients will commonly get food impactions. Or they may have achalasia, diffuse esophageal spasm, some primary underlying motility disorder that leads to food getting stuck. It may be that they're just eating too fast. So everybody in the room I know has a pelican within. So we've all had to eat very quickly at times to get to the ER, get where we're going. And your mother said, make sure you chew your food well, and there's a reason for that. If you don't chew well and you engage your pelican within, sometimes it just doesn't go down and make it all the way through. Other things that we see the reason for adolescents coming in and food getting stuck or a foreign body getting stuck is it's an intentional ingestion. So they'll do something on a dare. It's usually a teenage boy at recess or at someone else's home, and they'll just dare each other to swallow something. And then psychiatrically disturbed individuals account for the other ingestions that we see, people that just don't know what they're doing, not in their right mind. All right, so what kind of things have we seen that are, what kind of things are ingested and swallowed and don't make it through? Well, the type of foreign body varies with age. So little kids like bling, so they like things that are shiny. They love coins, toy parts, jewelry. Does anybody know what's the most common thing that we see that gets stuck in the esophagus? Coin-wise, it's a penny. So the government, back in the 80s, turned the copper penny, the most commonly swallowed foreign body that we see in pediatrics, they turned a relatively benign copper penny into a more caustic zinc penny, which if it sits there longer causes more problems. So thank you, government, for taking the #1 foreign body ingested in kids and making it a worse scenario. Adolescents and adults, the most common thing are meat. So either steak, chicken, hot dogs, or dental items. So be careful when you're seeing your dentist next. Where do things get stuck, or where does the ingestion typically take place? Well, little kids, unfortunately, it's while in the care of their parents. So you'd like to hope that they're with grandparents, with the babysitter, but it's usually while they're at home in the care of their own parents. And older children or adolescents, it's oftentimes at school. So during the school day when they're doing something on a dare or they're in a hurry to get out to recess, so they engage that pelican within and just don't chew very well. All right, so where do things actually get stuck? In the esophagus, there's multiple locations. Typically, the most common area is right below the cricopharyngeal muscle. That accounts for 60 to 70% of our foreign body ingestion hang-up location. At the level of the aortic arch, that's another 20%, and then just above the LES accounts for 10 to 15% of our patients. Other potential hangups are anywhere that there's a physiologic sphincter, so if things are too large to get through the pylorus, or if they are too large to get by the duodenal curve, or even at the ileocecal valve, that's another common hang-up. The duodenal C-loop, like I said, if it's too large, if it's more than 2 by 5 centimeters, typically we don't anticipate that it'll be able to maneuver the C-loop. Anyone with congenital malformations, sometimes they're undiagnosed, and this is the way that they actually present. This way we'll find some Meckel's diverticulum. And then if anybody's had a prior surgical anastomosis for any reason, those areas where the surgeons have reconnected the intestines, they're always more narrow than the native bowel. So those provide a potential area for a hang-up of a foreign body. So general rules that you need to sort of commit to basic memory or be able to look up. If a foreign body makes it into the stomach spontaneously, so if a kiddo swallows a coin, or another foreign body, and it makes it spontaneously into the stomach, that means that there's greater than a 95% chance that it's going to make it the rest of the way through the GI tract. So you sort of breathe a sigh of relief if, say, you're the parent and your child swallows a penny and you get an x-ray and it's in the stomach, you're like, okay, just calm down, 95% chance it's going to make it the rest of the way through. Exceptions to that rule, things that you need to say, wait, I need to think about something else, are again, the size matters. So if the foreign body is longer than 5 centimeters or if it's wider than 2 centimeters, odds are it's either not going to make it through the pylorus or it's not going to be able to maneuver that duodenal C-loop. So odds are we'll probably have to go get it out. And another important thing that's becoming more and more common is the ingestion of more than one magnet, or if a kiddo ingests a magnet in combination with a metallic foreign body within the 72 hours or less of the ingestion of the magnet, then those two things find each other within the body. So if something's in the stomach and the other foreign body, if they attract each other, even if it's in the colon, they can pull each other toward this. We're seeing it more with the new earth magnets. And a lot of toys and desk toys that people have as adults as decorative things have been pulled off the market in response to this, but it is a big risk, and children have lost their lives related to these magnetic objects. So we recommend that you don't have magnets as toys, and encourage people to do the same to avoid that in their homes. All right, so when does the ingestion typically occur? And children, again, it's while they're in the care of their family's home, so around noon to 6 p.m. is most commonly when the ingestion occurs. Older kids and adolescents, again, during school, and adults, it's with dinner. Presenting symptoms of foreign body ingestion, so the most common symptoms are difficulty with swallowing. So they're going to say it's hard to swallow, you're going to notice that they're drooling or they're not able to handle their own saliva, or they may have hoarseness of their voice. Additional complaints may be chest pain, so they may have odynophagia, pain with swallowing. They may have respiratory problems, so they may actually be wheezing, be in some form of respiratory distress. They may actually be vomiting because they may have an obstruction of either the esophagus or at the pylorus. And then a lot of times they can point to you, and they're pretty accurate with pointing where the foreign body has actually become lodged. And long-standing foreign bodies you also need to be aware of. Always, always, always think about a foreign body. If a child's gone from eating a normal diet and eating solids to only drinking liquids, always get an imaging photo to prove to yourself that it's not a foreign body. Because long-standing foreign body ingestions can present as either a chronic respiratory condition, such as chronic stridor, it can be chronic difficulty with swallowing, or even the neck mass. All right, what should you do? So I always say I look at this as when, people after the Super Bowl, they say, oh, so you've won the Super Bowl, what are you going to do? And they always say, I'm going to Disney World. This is one of those things that if you have a patient that comes in, what are you going to do, doctor, care provider? What's the first thing you're going to do? Well, remember we talked about kids like bling. So over 90% of these foreign bodies are going to be visible on a plain film. So the answer is I'm going to get a chest x-ray /KUB. That's the answer on the board, and that's the answer in life. It's the first thing that you want to do. It helps you to determine if the patient has had multiple foreign bodies ingested, so if you're up against one thing or you're up against multiple. It also helps you determine location and which doctor or care provider to call. So coins and foreign bodies, particularly coins that are in the esophagus, on the AP film, it's going to be heads or tails. So I always say, if you're going to call your gastroenterologist, memorize my face or one of the faces of one of the gastroenterologists you've met today. And if it's heads and tails on the coin, and heads and tails, when you look on the AP film, you're seeing the head of the patient, head of the coin, then look for a gastroenterologist. If you're seeing a side view, when you're looking at an AP view, if you see the edge of the coin, then you need a friendly pulmonologist visualized in your head, because they lay different depending on the cartilaginous rings. Ultrasounds and CTs, just bear in mind, those can be helpful for your non-radiographic bodies that don't show up, that aren't metallic. And this is especially important in patients nowadays due to body packer syndrome. So we're seeing cocaine, heroin, drug smuggling is increasing, unfortunately, throughout our country. And people are hiding drugs in various modalities. So, of course, it won't show up on a plain film. So if you suspect it, then you need a different imaging modality, and ultrasound CT scans are recommended. Okay, so again, this is just to show you, this is an example of when you would call your gastroenterologist. You see AP of patient's head, AP of coin, see my face, call a pediatric gastroenterologist. And then it's on the side film, you're seeing the edge of the coin. If, however, you see the reverse of that, if you see the edge of the coin on the AP view, then call a pulmonologist, because we're an ENT specialist to get it out of the airway. All right, so management of these foreign bodies. So patients that are symptomatic and have any respiratory distress or any difficulty with swallowing their secretions, they require emergent endoscopy, because the last thing we want them to do is aspirate, or the last thing we want them to do is take something that's an esophageal foreign body and bring it up and over into the airway, and then you're dealing with a bigger emergency. If you're not somewhere that you have access to a pediatric gastroenterologist or a surgeon that's familiar with endoscopy, some radiologists throughout the country are good at balloon extraction with a Foley catheter. So what they'll do is they'll turn the patient prone, they'll tilt them head down, and they'll carefully push through a Foley catheter, inflate the balloon and pull it out and bring the coin out that way. So if you're literally in the middle of nowhere and don't know what to do, that is an option. It's been deemed safe and very effective. All right, if the patient's able to swallow, has no respiratory distress, and that foreign body's in the lower 2/3 of the esophagus, then you can repeat the x-ray in 12 to 24 hours. Beyond that point, however, the foreign body, particularly if it's a coin, remember, if you knew the year of the coin, you'd be less stressed if it was an older coin, pre-1982. But if a coin remains in the esophagus for more than 24 hours, it does start to do damage. So you get mucosal erosions, irritation, and it can actually eat all the way through the esophagus. It usually takes more than a week, but just bear in mind, you want it out within 24 hours or less if possible. All right, what do you do if it's not just a coin or a smooth object? If it's a pointed or sharp object, such as a pin, a fishbone, toothpick, nails, needles, certainly an open safety pin, razor blades, dental retainers, those all have to be taken out immediately because they're sharp on multiple edges, pointed on multiple edges, have a very high risk of perforation and mucosal damage with every peristaltic action of the GI tract. Coins or blunt objects can remain in the stomach for 4 to 6 weeks. So remember I said if a kid swallows a coin, it lands in the stomach, 95% chance it's going to make it through the rest of the GI tract, and it's not an emergency as long as it's in the stomach, and as long as it doesn't land right at the pylorus and block the outlet to the stomach. But it can remain in there for 4 to 6 weeks, and beyond that time, if it's still there, odds are it's really not going to exit, so you may as well go get it out at that point because it poses a risk for lodging at the pylorus and causing an obstruction eventually. Longer objects, so we talked about that. So if you have an object similar to what the patient swallowed, if the parent can bring you the same object or if you can find it somewhere in nature and measure it, if it really is longer than 5 centimeters in a child or longer than 13 centimeters in an adult, it's really not going to make that duodenal C loop, and you may as well just go get it out. Because eventually it will cause a problem and it could erode through the duodenal wall. Condoms and balloons that contain illicit drugs, if you had done an ultrasound or a CT scan looking for the body packer syndrome, those need to be removed due to fragility. So we would never grasp them with biopsy forceps or any of our netting for fear that it would either puncture the balloon and release it or that we would somehow release the drug by trying to remove it. So that's a surgical emergency. right, this is, I like films that are kind of humorous. So this is a patient that was on our psychiatric ward years ago, and she was put there because she was going to harm herself. And the radiologist, the radiologist got this because the doctor walked into the room and saw the situation and went, "Oh no." And the radiologist literally read this as, "This patient is all screwed up." And these are screws scattered through the gastrointestinal tract. And what this patient did in the psychiatric ward is she took her fingernail and she untwisted all the plates to the electrical outlets and swallowed all of them. And so this is a scenario, and it's not a high-risk procedure. It's not a high-risk scenario. So it's already through into the intestines, and there's no sharp edge on both sides. Even if these were nails, because the heavier part of the nail would go through first. There's something called Jackson's axiom, which is the heavier part becomes the leading point. It's not the pointy part. Even if these were nails, it would still be safe to let it pass through at this point. But these were screws, so there's no risk, but she really was screwed up, and it's very sad. All right, so food and meat impactions. These are a common thing that we're seeing more and more of because of eosinophilic esophagitis. So it typically occurs in children with either congenital esophageal anomalies, such as a TE fistula repair, again, strictures related to reflux or motility disorders, the EOE, or achalasia or diffuse esophageal spasm. Steak and hot dogs are the most common offenders. Barium studies are not indicated. In fact, they're contraindicated. So if there's any chance that, if someone says, "I was eating something and now I'm having pain," or "I was eating something and now I can't tolerate my secretions, I can't swallow, I'm having pain," do not, under any circumstance, put contrast down that for two reasons. One, it poses an aspiration risk, because if you put fluid down there and it can't get by, they can cough that back up, choke that back up, and then aspirate it. And secondly, it makes it impossible for the gastroenterologist, the person who's called in to remove the meat impaction, to tell the difference between the human's wall of the esophagus and the ingested meat. So don't do it, contraindicated. Gastroenterologist may hurt you or choke you, and it makes it dangerous for the patient. Meat, unlike coins. So remember I said coins can stay in for about 24 hours before they start causing caustic damage. Meat is more dangerous because it's got enzymes of its own in there. So it can't stay in the esophagus for more than 12 hours without causing significant damage. And then back in the day, people used to give the enzymatic digestion, so the meat tenderizers that we use for our steaks when we're grilling this time of year, they used to give that in a slurry to patients to drink, but they discovered shortly thereafter that it turns out the human esophagus is the other white meat, and they digested the esophagus because it sat there, and it caused esophageal perforations in some individuals. So remember not to try to digest. The meat tenderizer is not going to know the difference between fresh meat and old ingested meat, so we'll just leave it at that. All right, so let's move on to button battery ingestion. So these are unfortunately still a common occurrence in the United States. There are over 2,100 ingestions that occur per year. Most common source of the battery is actually the child's own hearing aids. So don't think it's cute when the family says, "Oh, I taught little Georgie to change his own battery in his hearing aid." It's actually a dangerous thing for a child of any age to be playing with those button batteries. So please discourage that if at all possible. If it is suspected, you want to get an x-ray immediately. This gives you the position of the battery, so it tells you if it's in the esophagus. It means it's an emergency endoscopically. It means, gastroenterologist gets called immediately. We come in immediately. I have a couple GI fellows here. It means you don't stop, go to the bathroom. You don't stop and go to Starbucks. You run in, because within 4 hours, that button battery, because it can leak caustic agent, it can cause actually a low voltage burn. There's multiple mechanisms between potassium hydroxide and just the voltage of the battery that it can burn through the entire esophagus within 4 hours or less. So we know that at 1 hour that can cause problems, but within 4 it can be all the way through. And you just can't predict it, and there are deaths, unfortunately, still throughout the United States each year in children who have ingested a button battery. And we just didn't get to them soon enough, or people didn't suspect it. So if you suspect it, you get an AP view, and you always want to look, even if you get the story that my child swallowed a coin, Dr. Selva Kumar, when he was a fellow, picked up a case that got the emergency room call, kid swallowed a coin, and I just told you can let a coin sit for 12, 24 hours and it's okay, but in batteries you can't. He looked on the x-ray and saw that there was a double density. So you can see there's a step off between the anode and the cathode. And so it looks different. It's a ring within a ring on your x-ray, but always enlarge it. Look very carefully. If you can't take a pen or a pencil, a fine tip, and draw just one line around the edge of that foreign body that's swallowed, suspect that it's actually a button battery, and then call us to come take it out. All right, so what do you do if the battery makes it into the stomach? Well, if it's still in there beyond 48 hours, we typically will go in and endoscopically retrieve it. So it sort of also breaks the rule for the 95% chance it's going to go through. With these, we worry that they can leak the battery contents and cause either, again, a thermal burn or an alkaline burn from the battery. Prokinetic agents are recommended, laxatives, to hasten the transit through the gastrointestinal tract. So if it makes it into the stomach spontaneously, have at it with giving them polyethylene glycol or a stimulant laxative to get it to go through. If after 5 days the battery fails to move within the intestines, you make sure that a surgeon's on the case, and certainly if they have pain or peritoneal symptoms at any time, it may have to be removed by the surgeon. Complications reported: perforation, stricture, mercury toxicity, and there are multiple cases each year, unfortunately, of death. All right, other caustic ingestions. So the National Registry reports there's almost 2 million caustic ingestions per year in the United States. Majority of kiddos are less than kindergarten age, so less than 6 years of age. Most frequently ingested products include household bleaches, automatic dishwasher products, laundry detergents, swimming pool products, toilet bowl and oven cleaners. And as you go down that list, the further toward the bottom, they become more scary. So typically if someone swallows household bleach, or even like the hair relaxers are a more common thing nowadays, the odds of anything bad or permanent happening from those is much less. If you get a call about toilet bowl cleaner or oven cleaners, those are very scary. They're much more concentrated, and you need to take those very seriously and send them immediately to the emergency room. All right, so these are sort of things that you have to know in life and common for the board. So alkali causes a liquefaction necrosis. So that means that it can eat through, it penetrates deep, causing edema, cell necrosis, and oftentimes a full thickness burn. So alkalis are actually more dangerous than acids. So they can eat all the way through very rapidly. I always say this is what teenagers know this. When they're trying to commit suicide, they sort of research this out. And I look at this as the less filling, tastes great type ingestion because it's less bitter tasting than an acid. So they know they can get an alkali down in larger volume a lot quicker than it is to get an acid down. The damage is typically to the upper GI tract or lower esophagus, less often distally. So that's a difference also between an alkaline and acid. An acid's going to get your stomach. Bleaches are the #1 ingested alkali. Again, tend to have a benign course, rarely require hospitalization, and then the hair relaxers fall into this category as well. Acid ingestions cause a coagulation necrosis. So they self-limit because they congeal or coagulate, just like you're frying an egg. They're bitter tasting, so again, like if it's an accidental ingestion, little kids will stop much more quickly with an acid than they will an alkali. But these include your toilet bowl cleaners, swimming pool products, and the damage is typically to the stomach or the pylorus. A few years ago, we had a boy on a dare drink toilet bowl cleaner, and he had to have an entire antrectomy eventually because his stomach, there was just no keeping it open, dilating his pylorus. It was completely scarred off, and he had to have major reconstructive surgery. All right, so how do these people present? So the most common symptoms little kids will come in with are crying, spitting, coughing, like they were normal 1 minute, and all of a sudden they come in with acute onset of fussiness, irritability, spitting, coughing. They may be drooling. They may not be able to swallow their own secretions. They may be pointing and saying pain or it hurts, or may have pain in their abdomen a little bit lower. It's important to know that the presence or absence of oral burns is not predictive of esophageal damage. So I just quoted a little study there. It's actually the largest of its type. But just know that you have to combine your history, your clinical exam, and don't always rely on just because there's nothing wrong with the mouth. That doesn't mean that there's nothing severe going on distally. So management. At all costs, you want to avoid inducing emesis in these patients. So you want to keep them calm, quiet, just like you would with croup. You want to avoid at all costs them spitting up what they swallowed, because what burns or hurts going down is going to do the same thing coming back up. Do not, under any circumstance, give them a neutralizing agent such as vinegar or bicarb. So years ago, they learned the hard way that, Chemistry 101, exothermic burns can occur because of chemical reactions. So you can get not only the agent itself, but you combine something with it and you get a thermal injury on top of it. Administration of liquids to a symptomatic child may predispose to emesis and increase the risk of aspiration and further esophageal injury. So if they're having trouble already handling secretions or with swallowing, do not offer them fluids, make them NPO and put them on IV fluids. If they've got respiratory symptoms already present, you need ENT or pulmonary involved because you may need that airway protected pretty quickly. If the H&P, when you take it, is consistent with an accidental ingestion, so it's a little kid, they think a small amount of something, they show you the product, and you think it's it's like a hair relaxer, bleach, and it's a dilute acid or base, and the patient's asymptomatic, then you can trial a little bit of fluid, see how they do, and they can be discharged home without endoscopy. If, however, they're symptomatic in any way, and certainly if you think that it was a significant ingestion, either it was intentional, or the patient's significantly symptomatic from a respiratory or GI standpoint, then it's recommended to admit them to the hospital. And we perform endoscopy within 12 to 24 hours. We don't like to perform it earlier than 12 hours from the ingestion time because then we don't see the extent of the damage that's going to occur. And if we do it after 24 hours, it may be too late. So it's really it's a fine window that we like to operate in because after 24 hours, there's an increased risk of perforation of the GI tract just by us being there and adding air and pushing our scopes through. So this certainly isn't anything that you need to memorize, but just know that we have a grading system for when we do the endoscopy and we look at what the injury actually is to the esophagus. So grade 0 is if it looks normal, everything's fine, no problems with the esophagus or stomach. If in the esophagus there's superficial redness, we call that a grade 1 injury. If there are hemorrhages, exudate, linear erosions, ulceration, but it doesn't go all the way around the lumen of the esophagus, then it's a 2A. And then 2B and 3 are severe. So that's either the injury goes all the way around or there's deep ulceration. We're already seeing eschar formation, sort of like what I showed you with the pyoderma gangrenosum earlier. Then that's a very high risk for perforation. So it changes the way that we deal with these patients management-wise based on the grading at endoscopy. So if they're a grade 0, grade 1, grade 2A burns, then we can start them after endoscopy on clear liquids and discharge them home when they're able to take PO well. And there's typically no long-term sequelae for those patients. If, however, they had the burn that went all the way around in any position of the esophagus, or certainly if they had the more severe burns, then there's more than a 70% chance of eventual esophageal stricture in their lives. Typically, we will, in the acute phase, put an NG down. While we're looking at them endoscopically, we'll place it under direct visualization. And it's not only for nutrition, because they're not going to be able to swallow, but it's also to stent open the lumen of the esophagus to keep them from forming a complete stricture and obstruction of the esophagus as things heal over the next few weeks. And then the use of corticosteroids and antibiotics is controversial. But a lot of us will tend to use corticosteroids as an anti-inflammatory, and because we're worried about bacteremia and the risk of sepsis, we will give IV antibiotics. Also, what you need to know, as far as alkaline burns, if a patient has a significant lye burn or alkali burn, they have a greater than 1,000-fold increased risk of esophageal squamous cell carcinoma later in their life, and it typically is 40 years in the future. So you need to make sure that you check that, tell them, you have this risk, make sure you see an adult gastroenterologist the rest of your life. If they follow you if you're the pediatric care provider and they follow you to age 21 or 25 or 35, tell the husband or wife, turn them in, to an adult gastroenterologist for routine monitoring. All right, so let's go over some questions. And these are common for what you'd expect to see on your test. A 2-year-old boy has just swallowed a nickel. So parents witnessed it and saw it because it was in their house between the hours of noon and 6 o'clock. Physical exam reveals a quiet child in no distress. The most appropriate first step in managing this patient is it administration of glucagon, IM? Glucagon will relax the lower esophageal sphincter in some patients, by the way. Is it administration of papain, which is one of those enzymatic meat tenderizer type meds? Admit for observation. Would you get an x-ray or would you perform endoscopy? Remember, your gastroenterologist has kids to put through college and graduate school. So what would you do? Wow, almost 100% of you got that right. So yeah, it's the you just won the Super Bowl, what are you gonna do? You're not gonna go to Disney World, you're gonna get an x-ray. So good job, that was really good. All right, question number 2. A young child has swallowed a penny. The x-ray reveals the coin to be in the stomach. What is your next and most appropriate step? Is it A, the child should be given Ipecac to induce emesis? Should the child be admitted and observed for signs of intestinal obstruction? Should the child be sent home and the mother instructed to examine the stools? Or should the child be referred for endoscopic removal of the penny? So it made it into the stomach. What are you going to do? Good job. So remember, the rule is if it makes it into the stomach spontaneously, odds are it's going to greater than 95% chance it's going to make it through the rest of the GI tract. Because it's a non-caustic, round, non-sharp foreign body, the mother should just be told you can take little George home and screen the stools, and if you don't see them within 4 to 6 weeks, come back, we'll get another x-ray, and if it's still there at that point, we consider taking it out. All right, question number 3. A 3-year-old female is found crying and drooling with an open container of oven cleaner. The bottle is half empty, or I like to look at it as half full, if you're optimistic, and it wasn't that bad. On exam in the emergency room, she has blisters and ulceration of her lips and buccal mucosa. The initial management should include which of the following? Should you A, administer Ipecac and decrease the amount of caustic agent in the GI tract? Should you B, administer milk or a neutralizing agent? C, put an NG down for gastric lavage? Or D, make her NPO, give her IV fluids, and admit her? What would you do? You are the first group who's ever gotten this all right. Good job. You guys are so smart. So absolutely, you want to avoid it all at all costs, making that fluid come back up and burning a second time, or you want to avoid an exothermic thermal reaction. So smart cookies. Good job.